A very good evening. And Vipul has promised me to give 5 extra minutes because I have 140 slides. I hope you will survive my 140. And speaking in front of Dr. Rajapurkar sir is like giving a viva. So I am already having butterflies. So just bear with me. So see, what we are discussing since morning is this. We are looking at extracorporeal blood purification. It is the onus is on us to clear the blood out of the toxins. And the goals of the extracorporeal blood purification is not only to remove the harmful substances, but to give the useful substances. And throughout the journey of dialysis in last say 50 to 60 years, we could find these 3 modalities. First is hemodialysis, which is just a diffusion based mechanism where we can clear small molecules. Second invention was hemofiltration. The filtration means we put something in the patient's bloodstream, a very high volume of water, and we take it out through ultrafiltration. That happens a solvent drag, that is convection. The third thing which has come into vogue in last say 15 to 20 years is hemoadsorption. At the outset, I must say that hemoadsorption, hemadsorption and hemoperfusion are synonymous terms. They are used interchangeably in the literature, in the studies and in the textbooks. So this is about, I am not going to talk about hemodialysis, I will be restricting myself to hemadsorption. And this is the outline of what I am going to talk. First thing, I would like to introduce you what is the topic. So when we talk of extracorporeal blood purification, we are talking about MOST. The MOST is multi-organ support therapies. So at one therapy, we are trying to support the kidney, the heart, the lungs and the liver. And now we are focusing on this, which is the targeted removal of mediators of sepsis. We know that there is a scarcity of antibiotics. We know the survival in sepsis and septic shock is just 40% in high-end ICUs also. So we are focusing on this particular domain when we are talking about MOST. And these are the options available. If you look at the plethora of these options, there is one thing which is standing out is the adsorption therapies. With all these therapies. So it's not only a standalone therapy, it can be an add-on on the existing therapies of extracorporeal blood purification. But why do we need this hemoadsorption? Because there is a gap in the molecular weight where we can clear the blood of toxic substances. So we saw we can clear say up to 1500 with dialysis, okay, up to say 30,000 Daltons with hemofiltration. But when it comes to a molecular weight which is nearing albumin, which is the molecular weight, which is the maximum molecular weight which passes through the glomerular filtration barrier. So that particular is the gap where we cannot clear the blood of the albumin bound or protein bound substances. But we can do that. We can do that with plasma exchange. But we need to infuse plasma. So it comes with a cost. So now we are looking at a therapy which will take care of the protein bound toxins, but we are not required to give anything to the patient. So it's a selective removal of the protein bound toxins. And these are the 6 principles with which the hemadsorption works. See, it is not a covalent bonding between the adsorbent and the toxin. It is the ionic bonding. It is the van der Waals forces. It is the antigen-antibody bonding, and it is bioaffinity. But the thing which depends the performance of the sorbent, the adsorbent is short form for a sorbent. It is the hydrophobicity. If it is hydrophilic, it will swell in no time, the moment it is exposed to the blood water. Alright, so these are the 6 principles with which the adsorbent will work. You can look there is a hydrophobic reaction and it is a macroporous adsorbent. It is thus attached to the moiety which is removing it. So it is saturable. And this is the thing which was found when the adsorbent cartridges were used for immunomodulation. If you look here, it is selective versus non-selective. It is the pore size which determines which is to be removed. If you have a very large pore size, what will enter it will be blood corpuscles, very large proteins and albumin. We don't want that. So we have a control on the pore size which initiates the mechanism of adsorption. So it is like it is the sorbent, it is concentration dependent, and the key factors are ionic bonding. And what are the options we have? We have a plethora of options. These are the predominantly seen adsorbent cartridges. On left hand, these are most talked about adsorbent cartridges. We'll see it one by one. But which is the key sorbent characteristics? It is the biocompatibility. It should not lead to any allergic reactions. Second thing, it is the porosity and surface area. If you look at most of the adsorbent cartridges, they are of 45,000 to 60,000 meters square, which equals to almost 8 to 10 football fields. It is that enormous surface area, and that is the reason it removes the cytokines, leukotrienes, mediators of sepsis, DAMs, TAMs, endotoxins to a very large ability. See, CRRT can clear a molecular weight of almost 40,000, but its removal ability, the sieving coefficient, is finite. The adsorbent cartridges, just because of their surface area, it's infinite. And the molecules which are used for sorbents are only 3. The first came was charcoal. Okay, it was the primitive I don't know if anybody of you used it, but we used it for removal of toxins. It was for poisonings. Okay. The second thing is polymeric resins, which is now being used widely, which is divinyl benzene, and it depends on the specific pore size. So this particular thing is non-specific but targeted. It will target a particular molecular weight as per the molecular weight of the desired molecule to be removed. Okay. So if you want, say, a poison to be removed, you have a different cartridge. If you want to remove a bile salt, you have a different cartridge. You want to remove only protein bound uremic toxin, you have a different cartridge. So this is the way it works. Affinity ligands are the ligands which came after 2002, after trials like UFAS, Euphrates, Abraminix and all that. We'll see it shortly. So they have the toxic material into the blood have affinity for that particular moiety, which is here polymyxin. So instead of giving the antibiotic systemically, we are exposing the blood to the antibiotic locally. So we won't have any systemic undesired effects of the antibiotic. At the same time, this will bind to the specific targets, which is the endotoxins. So this is how it works. So it is basically a molecular weight cutoff therapy. So molecular weight cutoff therapy means if you have a pore size very small, you may end up clearing only small molecules. Okay. If you have a very large size, the cells may get into the pores, and the very purpose of adsorption will go. But the middle path, where the size is 5 to 60 kilodaltons, that is the proper way where we expose the blood to these particular sorbents. And this is the nanotechnology which is giving rise to these pore sizes. So this is basically a cytokine sink. We put all the cytokines in the adsorbent, it adsorbs it. And this is how it works. So how to proceed with hemadsorption? The bane of all this program is patient selection. So proper patient selection, then we need to have an vascular access. Then we need to prime the circuit with saline. We can't prime it with any other things because it gets saturated. Okay, no plasma priming, no blood priming, nothing, even if it is a pediatric patient. Then we start the treatment and then we start the monitoring. We monitoring those toxins for which we have started the therapy. For example, somebody has started for TNF alpha, we need to monitor it. If you have started for interleukin 6, we have to monitor it. If you have started for endotoxin, you have to monitor it. How much is being removed? And this is how we monitor it. So first and the foremost thing for which hemadsorption started was hemodynamic stability. So we need to see whether the vasopressor dependency index is coming down, if the vasopressor dose is coming down, if the biomarkers in questions are coming down, and then the cartridge saturation. This is most talked about and the most curious part of the hemadsorption techniques. See, we use something called as ion exchangers in our RO plants, okay, and we regenerate it with hypotonic sodium, and we remove the adsorbed materials and everything regenerates. That doesn't happen in hemadsorption. Theoretically, it's very attractive concept, but it doesn't happen. So these are single-used cartridges. We cannot reuse. Okay, and they are concentration dependent. If there is a high concentration of the toxin in the blood, these cartridges are going to get saturated quickly. And if you continue using them for a longer period of time, the back diffusion happens. Whatever is adsorbed to the membrane will get back to the blood. Alright, so there has to be a time component, there has to be a patient selection component, and there has to be a targeted removal of the toxins component. So with this introduction, let us revisit our uremic toxins. This is what we talk about. So this for 2003 UTOX. If you look at 2003 UTOX, they have talked about protein-bound toxins, but they don't talk about the clearance efficacy to the extent that 2021 consensus guideline talks about. So 2021 talks about not only the toxins, it talks about the various clearance strategies. So for example, if you have a protein-bound uremic toxin causing pruritus, it tells us to do adsorption or high cutoff membrane. If you have a small molecule creating the trouble, it tells our low flux hemodialysis with pharmacological intervention. So this is how it has evolved from 2003 to 2001, and now we are understanding that the uremic toxins are not only endogenous, they are exogenous also. And the removal strategies for endogenous and exogenous cannot be same. Okay, so these are the toxins what we are talking about. These toxins create the most striking characteristics of symptoms called syndrome in a patient with on maintenance hemodialysis. And now 2021 talks about checking their levels. We used to check only creatinine, urea, potassium, bicarbonate. We never thought of checking beta-2 microglobulins on a routine basis. We never check cresol sulfate on routine basis. Okay, the 2021 tells us that you have to check it in the uremic patients and compare it with CN. N is normal. Okay, and if you have to see the Cmax and Cu also, whether the distribution of the toxin is even or uneven. If the distribution of the toxin is even, most likely the convective modalities and the diffusive modalities were better. If it is uneven, probably you have to supplement these modalities with hemadsorption techniques. So now we come to this. So we can see that there are exogenous molecules, there are endogenous molecules. And every modality, if you see, has one or the other limitation. If you look at the low flux HD, we can't take out the gut derived proteins which are more than say 60,000 Daltons. We can't take out the beta-2 microglobulin. If you go down, the online HDF can take out everything except the large molecules which are around to the tune of 50 to 170 kilodaltons. But the lower down, the lowermost is hemadsorption, which can remove all of them. And just imagine if we combine low flux hemodialysis with a hemadsorption, their ability to clear goes high up. So we are not talking about hemadsorption alone. We talk of HF, HA. So high flux hemodialysis with hemadsorption. Low flux hemodialysis with hemadsorption. So HA, HD will give you small molecular clearance, middle molecular clearance and protein bound clearance, which doesn't happen if they are being used alone. So this is how the concepts are now changing. With this, let us move on to our favorite topic, how we apply in sepsis. So I'm going to talk about just 4 filters. There are multiple filters, but just 4 filters for the sake of time. This is toramyxin. We know the antibiotic. It's an antibiotic which is immobilized on a polystyrene based complex. It has no dialysate running. So it is just the blood which is exposed to the column goes back to the patient. Unwanted endotoxins get adsorbed, the blood is returned to the patient, there is no dialysis. So this has happened and this is being studied for quite some time. So there are multiple studies like UFAS, Euphrates, Abdominix and everything. I have just make some red boxes here for you to highlight that endotoxin assays were measured only in initial phase of time. After that, it was a syndrome complex. Everything was based on SOFA score. Everything was based on Apache score. We don't have to check these assays in the studies to come. If you look at the initial studies to UFAS, it gives very good results. But after that, when the Euphrates came, it was almost a negative study because it didn't give us anything after 28-day mortality benefits. But it did give us reduction in the vasopressors. It gave us ventilator-free days, but the mortality benefits were not seen. This was post hoc analysis. In post hoc analysis, what happened? The investigators found that when the endotoxin assays were checked, the patients who actually had higher endotoxins were not given the benefits of the filter. So it was something like those who were requiring it were not given it. And those who were given it were given at a later period in the disease trajectory. So if you look at the UFAS, which paved the way for Euphrates, which showed us a very significant mortality benefits, because probably it was severe sepsis and very small sample size. But if you look at Euphrates, it did not show us any significant benefits. So why did this happen? It was an overall problem, the problem of overall, because it was given to overall patients. It should have been given to selected patients. And it was the post hoc finding that did show significant mortality benefit, but it highlighted the critical need for patient selection. So if our patient selection is good, probably these cartridges will work well. Then came, after all this, it came a national-wide observational study which gave us a survival benefit in these patients. When the SOFA score was checked, it was not EAA, endotoxin assay, not there. It's a syndrome count. When the SOFA score was checked, it gave us the same benefits. And with this, it's a very busy slide. I'll just tell you, it is still a work in progress. So now the focus has changed from the endotoxin biomarkers to the severity. Cytosol, we are familiar to it. And this is my favorite slide. If I have to explain this slide, it will take at least a day. All that I will tell you, number A is your patient. You are giving a standard line of treatment to him, and you hope the number A patient will reach B, which is recovery. All right. Meanwhile, the patient can have a cytokine storm or may have early death. Or the patient will have severe immunosuppression going to even paralysis. So we don't want our patient to go to C or D. All right. But this is a matter of time, not a matter of chance. Okay. But if you give a cytosorb, the patient will not reach B, the patient will reach E. So the recovery happens earlier than the recovery with a standard line of therapy, like antibiotics, steroids, whatever you give. All right, so this is how this diagram is all about. And you know the cytosorb, it removes the cytokines. It's a divinyl benzene polymer, 45,000 meter square is the area. It removes the small and middle sized hydrophobic molecules, and it removes all of it. People have tried it in snake bite, organophosphorus poisonings, liver failure, rhabdomyolysis, you name it, and people have tried it. People have tried it in all patients of COVID, including us. Okay, but what it doesn't remove is the immunoglobulins. It doesn't remove the clotting factors. Okay, and this is the spectrum of molecules based on the molecular weight which it removes. So how do we do that? It is not a standalone adsorption. It has to be coupled with all these therapies. We can couple it with hemfiltration, ISD, CRRT, ECMO, cardiopulmonary bypasses. So it can be actually placed into the ECMO circuit if you want the cytokine storm to go down, particularly after CABG patients. And the efficacy, yes, it brings down the cytokine levels, it brings down the mediators of sepsis, and it frees the patient from the vasopressors. And these are the few studies. I'll just look, other results are reduction in IL-6, significant reduction in vasopressor dependency. That has been undoubted for cytosorb. In Indian data, it was mostly seen in septic patients, and this is the data from which studied 100 patients, and they looked at the biomarkers of sepsis, and they found it working very well if initiated within 48 hours of sepsis. So the timing was interesting here, and Dr. Sathe Madam's paper. So she studied 45 patients. This was a very good paper because it has a control limb also, and she could prove that the benefits of survival were in 75% of patients when cytosorb was used compared to the standard line of therapy. So we have plethora of papers, not only in sepsis, they have seen in snake bites also. So this cartridge was most studied and probably needs to be studied more. So in meta-analysis, they have found that it is associated with lower IL-6 level. This was proven. We are not talking about mortality benefits, but we are talking about the removal of the drivers of the sepsis. The question comes when to use it. So this is a cyto score. Okay, very simple score based on 7 parameters. If the score is more than 6, use it. Okay, this is the patient selection. It has to be used within 48 to 12 hours to 48 hours of onset of sepsis. And how do we do that? So we can do it in 3 ways. Okay, you can use it in simple circuit of cytosol, nothing else. You can couple it with a plasma exchange. You can do that. Or you can do it plasma filter plus dialysis filter plus cytosol. So this was seen as coupled plasma filtration and adsorption using a cytosol. But the cartridge can be anything. So it's just a sorbent. Okay. And this is a busy side. I won't go in detail in that. Second is hemophil. Hemophil is a very, so up till now what we saw, there is no dialysate. Okay, just a cartridge. We run the blood and give it back to the patient. This particular membrane is a PMMA membrane. Okay, this PMMA membrane gives us benefits of not only immunoprotection, but it gives us a immunomodulation also, and it is a renal support also. So we can run a dialysate on the other side. It works just as a sled. It's a sled membrane. All right. And if you have machines like Asahi, which are CRRT machines, can be used at hemodiafiltration also. So it is dual benefits. And if you look at the centers, familiar names, Rishi Deshpande sir, Mehul Shah sir, they saw it in COVID-19. So it was beneficial in COVID-19. Multiple patients have used it. And this is in vitro study for cytokine purification, where it was head-on compared with cytosol. And they could find it non-inferior to the cytosol. This is from, again, from the sepsis and septic shock. The use of cytokine adsorption with PMMA brought down the vasopressor dependency index significantly in this particular paper. Then we come to this. Okay, this is the most talked about cartridges now, widely available, very nicely used. And they have come up with a concept of selective non-selectivity. Okay, so when they manufacture these cartridges, see, it is a macroporous resin which is made up of vinyl benzene. Okay, the material is the same. What differs is the surface area of these cartridges and the size where the blood comes in contact with that sorbent. So based on that, we have HA130, HA230 and all that, and they are for different indications, not only for the patient's body surface area. They are for different indications. Okay, so if you want to do for chronic dialysis, you prefer HA130. If you want to do a hemadsorption for toxins, you prefer HA230. If you want to do it for acute inflammatory conditions like sepsis, burn, trauma, pancreatitis, and even some patients of SLE, you prefer HA330. Okay, so it's a tailor-made hemadsorption cartridges which are introduced by this. And there are multiple trials here, but I will just like to show that it is not only the removal of the mediators of sepsis, but there is mortality benefit also. And when it is compared with cytosol, yes, definitely the cytosol removed it much better, but it is a bench top model. So we have, when we head-on compare with cytosol and other new coming hemadsorptions, they work equally well. It was a retrospective study which had HA330 perfusions for 3 consecutive days, and it gave good results. All right, and this was a retrospective analysis. It was a 4-hour HA330 session, but the crux of this is that it was mainly focusing on septic patients. No other patients were studied. And this is one more meta-analysis, but this is a retrospective study. So these are like tuned for the need of the patient. Cytosol is one for all. HA series is one for one for another. Okay. So first we saw only blood running through the membrane. Then we saw a filter which is with the dialyzer. Then we see the auxiliary. This is CRRT. We all know. And these are 3 layers. One will adsorb the endotoxins, 1 cytokines, and 1 will remove the uremic toxins. It is a CRRT filter. It is saturable, doesn't work more than 36 hours, but it is coated with heparin. Okay, and then these are the benefits, and I think I'm running short of time. I have much time, right? So these are the advantages. So it is one in all filter. It will work as a CRRT membrane. It will work as a hemadsorption. It will work as an immunomodulator. Okay, and these are the few studies which are from Indian patients in USA in COVID area. This was beneficial, and this was seen in septic patients. This was a case series by Mr. Falco, and it worked very well in sepsis. Mortality benefits were seen. So up till now we were just seeing the biomarkers going down. Now we are talking about mortality benefits, and it was seen in this New Delhi paper by Dr. Govil's unit. It showed not only mortality benefit, it will show cost effectiveness also. Okay, and this is familiar names for you, Dr. Lobo sir, Dr. Vipul, and it was demonstrated that the CRP, ferritin and D dimers went down. Okay, this was a randomized control trial. So up till now, most of the literature is talking about case series, retrospective data analysis, but this is particularly randomized control trial, which gave us that surgical septic shock did better than medical septic shocks. So it had an edge when we are using in surgical ICUs. So if you summarize the auxiliaries, it removes the drivers of sepsis, but we need more RCTs to prove it in all conditions. Can we use it in liver? Yes. In liver transplant patients, when you are using auxiliaries, it will not only remove the uremic toxins and the mediators of sepsis, it was seen to remove some hepatotoxins also. So this is how the journey of adsorption has come to this end. So what we talked about up till now, we were talking about removal of cytokines, products of bacteria like the cell wall membranes, the endotoxins, the subcellular components. Now we are talking about removing the entire viable bacteria. Okay, so this is a Seraph filter which is capable of removing all these microorganisms. Alright, and it was proven that in a patient who was a transplant recipient having say a viral infection, like say this particular had an adenovirus, okay, when we expose him to the Seraph 100, it brings down the viral load, it brings down the bacterial count, and Dr. Ronco has very nicely demonstrated this. These are petri dishes, okay. So the patient is exposed to Seraph and the blood is drawn at 1 hour, 2 hour, 4 hour and 6 hour. You can see visually the colony counts. So now we are not only removing the molecules, we are removing the viable bacteria in a condition like bacteremias. This is how it is working, and it has evolved to this now. Now we are planting the immunoglobulins on the membrane. Alright, the immunoglobulins are planted on the membranes. It can remove the bacteria and viruses. So this is the Garnet hemofilter. Alright, so this is how we have come to this end. What about ESRD? This was a KDIGO conference. I just like this KDIGO conference because this was a conference where patients participated. We all are discussing here about the patients, and I cannot see any patient here. This patient has drawn this diagram and she has told what she is suffering from. Okay, so she suffers from fistula pain, shaky nervous systems, itching, and her restless leg syndrome and all that. So this KDIGO conference addressed this by talking about usefulness of hemadsorptions. So I saw you the plethora of hemadsorption filter. This is HA130 for hemodialysis patients. So we can do hemodialysis, hemofiltration, and this is hemadsorption. Okay. So where we apply this patient? It is applied for very specific indications. Hypertension, which is not controlled, pruritus, not controlled, appetite, anemia, EPOFIT resistancy, and dialysis related amyloidosis. So in all these things, when this Shanghai paper came out, they coupled, so we are not talking about stopping hemodialysis. We are trying to couple dialysis with something added benefits of hemadsorption. So on this side you can see HD, HF, and once in 2 weeks one hemadsorption. And this is standard therapy. And you can see the lower beta-2 microglobulin, lower parathyroid hormones. We have lesser pruritus. This I could get this picture just to show you that those scars are not because of any disease. It is because of the patient itching so hard, it is inflicting the injury to his back. Alright, so this is to be dealt with. Okay, and this is what HA130 talks about. It reduces the uremic toxins and hence reduces the pruritus. Okay, it can deal with the amyloidosis. It is the middle molecule, beta-2 microglobulin, it can take care of it. It goes down and we usually check it. Our cutoff is 20,000. The moment our dialysis patient goes below 20,000 of beta-2 microglobulin, we offer it. Okay, and I'll just go resistant hypertension. If you look at this cartoon, if the individual is using 1, 2, 3, 4, 5 BP tablets, and if still BP is not controlled, we have to do something about it. On this side, the green part, that is controlled resistant hypertension. We are not talking about controlled resistant hypertension. All right, we are talking about uncontrolled refractory or resistant hypertension. These people, they benefit with HA130 because of removal of the middle molecules. And the middle molecules we saw in the previous diagram of 2021 UTOX consensus statement. Resistant hypertension can be treated well. Sleep disturbances, because we are treating the low melatonin, pruritus, chronic pain, the sleep gets better, and hence the quality of life. We can treat the secondary hyperparathyroidism. We can take out the care of FGF23, and that all adds to the quality of life. Okay, and does it affect only quality of life? No, it will affect the survival also. So now we are moving from only control of the symptoms to better survival. All right. So this is how it works. It works on the intestinal microbiota. So in previous diagrams we saw there are endogenous uremic toxins. So these adsorption cartridges can take care of the endogenous uremic toxins, not only exogenous. And this is the summary of HA130. It can be used in all these gamut of conditions. Coming to the last part of my talk, it will take just 5 minutes. No problem. I can stop here. No problem. Thank you so much. Thank you so much.
I have a practical question. When we couple hemadsorption or any sorbent with the dialyzer, should we connect it pre or post dialyzer?
Post.
Post dialyzer. And it can take blood into it.
We can except the BS330 and BS80, which is used for liver failure patients. We can either use a plasma separator and expose the plasma to the adsorbent column, or we can expose the blood directly to the adsorbent column. When it comes to ion exchanger, just because the RBCs are negatively charged, we cannot expose the whole blood to the adsorbent column. We have to separate the plasma and expose the plasma to adsorbent column. That happens only in BS330, BS80. If you are using HA230, HA330, HA380, HA130, you can use the expose entire blood to the column. Only thing we learned in a hard way, that in a patient with poisoning, it is always better to separate the plasma and expose it to the membrane, the adsorbent. The clearance becomes faster. This is only, I would say it is off label, but this is how it should work.
Girish, all the studies are showing vasopressor improvement, cytokine reduction, but every randomized trial in sepsis of extracorporeal therapies has either shown no mortality benefit or actually harm.
Yes.
And cytosorb performs worst.
Yes.
In the ECMO patients of COVID, the mortality was 3.5 times higher with cytosorb.
Yes.
In the Shadler's randomized paper which you showed, the 60-day mortality was significantly higher with cytosorb. So I'm extremely reluctant to use that device outside a clinical trial, since even the two systematic reviews are suggesting that there are subgroups of patients where the mortality was higher and that there is no group where the mortality was significantly lower. As far as oxyris and hemophil are concerned, since they are doing renal replacement therapy, no question.
Yes.
You can do it for that, and if you are getting some additional benefit, great. Polymyxin, would you want to comment? The Tigris trial just got over about a month and a half ago.
Tigris,
the preliminary results seem to suggest that it's going to, polymyxin is going to come back.
So we are having a return of the dragon now. The polymyxin is coming back. So Tigris 1, Tigris 2, there are two trials which were performed in a plethora of patients based on what I was talking to you about, not EAA based. Okay, it is now syndrome based. And the polymyxin B, if done within 6 hours of sepsis window with a SOFA score of 6, they are performing better. But it has to be done for 3 consecutive times, and then for 6 hours of 6 hour duration. that is what I think 6 or 12 hours duration, then you have to remove it. This is Tigris 2 is coming, but it's still gray zone.
Because I would find it very difficult, and I think any of us would, to say to any patient or their relatives, look, here's this treatment, it's extremely expensive. It may not make a difference whether your patient lives or dies, but he will die with lower cytokines and a better blood pressure and a better oxygen saturation.
Poisoning? Yes.
Poisoning, yes. Paraquat, because the mortality is 100% without a treatment.
We tried in oleanzapine, we tried in yellow phosphorus, we tried in paraquat.
Paraquat. We are using.
The other day we discussed about snake bite works.
With paraquat, and now the dithionate test kit is available.
The urine kit is,
so you can demonstrate that.
We can demonstrate is going down actually. It comes with the filter, okay. If you are buying the filter HA230, the vendor will give you that kit to see the levels in the urine.
So, what is the smallest weight we have tried this, like pediatric patients?
Pediatric, I usually prefer a CRRT.
Okay.
But in liver failures, we have tried about BS 80 and HA 60s. But that comes not without a plasma exchange. So we have to have plasma separator platform, and plasma has to be removed and run through the 2 filters. I mean, it is like for liver actually, PALF. I would. It is the liver that gives you more. I will just show you this cartoon here. So this is called mini DP mass. So this is liver failure. Okay. So this is how these things are taken care of. This is mini DP mass. So this is adsorption. If you remove the one cartridge BS, if you remove, it becomes a detoxifier. You can use it in toxins like other toxins, middle molecular toxins. But without plasma filter, we can't do that. That is the only issue with this. But CRRT, yes, I would always prefer a CRRT because it can take care of molecules up to 40,000 Daltons. And if you are going the right dose and filter life is good, I think it works well.
Aniket?
Sir, how frequently do you suggest the use of this HA130? Can we offer to the patient once a month?
No. See, this is a Shanghai protocol, but what we customized it. So first 2 weeks we do twice a week. Next 2 weeks once a week. Then every fortnightly. And that has to be continued for at least 12 weeks. At the end of 3 months, we check the beta-2 microglobulins. We check the patient's quality of life parameters, which is KDOKI certified scale, and we see how it's responding. We could use it in a patient who had cognitive decline, a very, very senior gentleman, and we found excellent results with HA130.
Sir, and with paraquat, do you have any suggestions as to how fast and when and everything?
We don't have.
No, not the HA230 is what.
HA230 works very well.
Works very well.
Very well.
And if initiated within?
As soon as possible. I mean,
As soon. If the patient reaches you more than 24 hours late, nothing works in paraquat because lung fibrosis has already started.
Lactates are going up, bicarbs are going down, transaminitis is set in. It's usually we have missed the bus. So you have to do it as quickly as possible.
And even if there is no renal failure,
Yes.
do you want us to combine it with dialysis or only the standalone HA230?
If it is no renal failure, standalone.
Standalone
It's
HA230.
your decision whether you separate the plasma and run it through the HA230 or you expose the blood to the HA230. But if there is a renal failure, then only dialysis. Otherwise, it's a standalone.
Standalone.
And what is recommended or what will become a protocol now is after you've demonstrated a negative dithionate, 8 to 16 hours later do the dithionate. If it becomes positive again, that's the time to go for a second HA230.
It's a distribution of the toxin.
There's redistribution of that.
Thank you for a nice lecture, sir. What is your opinion about absolute cytokine levels first to recruit the patients and to apply a second filter. So will the levels help us in recruiting?
We are not now inclined towards levels. We are inclined towards the patient characteristics. So if the patient is sicker and if the levels are very low, we can safely say patient is in immune paralysis state. So the downward portion of the graph, okay, you have lesser immunostimulants and immunosuppressants are gone down. So either way it's a big concern, you have to take it out. So it is the patient's SOFA, Apache 2 that will determine your decision to have a cytokine or immunomodulator in place, not the numbers. We are Tigris, that's what we are talking. We are moving away from the numbers now. We are looking at the patient's overall characteristics.
But Tigris only recruited patients whose endotoxin levels were between 0.6 and 0.9. So they could, after that, they have a very select group of patients.
More than 0.9, they did not. That was exclusion criteria for them.
Exclusion.
And about the points Lobo sir was making, that whether cytokine reduction therapies can be restricted to the small subset of patients like pancreatitis or acute surgical sepsis, only those ones.
In surgical sepsis, the same thing, the point about Abdomix is that surgical source control is achieved. So after that, do you really need cytokine removal is an open question, and Abdomix actually suggested it didn't work because they randomized patients to they achieved surgical source control in 92% of their patients, and then they randomized them. They checked appropriateness of antibiotics, 90% of patients, the initial antibiotic was up, and then when they randomized them, there was no mortality benefit and actually a slightly higher need for RRT in the group which got polymyxin hemoperfusion.
Sepsis 3 also, they are saying about adjunctive therapies. They are not talking about mainstream therapies. In sepsis 3 also, there are adjunctive therapies which will help your standard of care.
I don't think cytokine levels, you can ever get them fast enough or get all of them in time to decide that on that basis you're going to recruit patients. Even that is perhaps this about AKI subphenotypes, which we are talking a lot about, but many of them are identifiable only by chemical parameters and maybe AI in the future.
Thank you, sir.
Girish, I think I did injustice to you by giving only 20 minutes and last
You gave me 5 extra
20
minutes.
session.
That is enough for.
So next time I'll take care of it. I'll give you prime time maybe.